This conference will now be recorded.
Student to join IPL. Hello, good morning to everybody. Am I audible?
Yes, sir.
So we'll discuss BREECH today. BREECH presentation. That is, we'll discuss BREECH presentation. Okay. It is. So what is BREECH? It is all these things. We know normally that during pregnancy, late pregnancy, before delivery, that patient has to deliver. That before delivery, patient lie in certain position inside the uterus. Most of the time, it is normally the presentation is cephalic. Almost more than 95% is presentation is cephalic presentation. But sometimes we have breech presentation. Breech presentation. So what is breech? Breech is longitudinal lie. You know this patient, this baby lie is longitudinal. It may be longitudinal, it may be transverse, it may be oblique line. So longitudinal in either it can be a cephalic presentation or a breech presentation. Whereas in cephalic presentation, that is, the head occupies the lower pole of the uterus or cervix close to. So that is lower pole of the cervix, that is cephalic presentation. Here, this buttock occupies the lower pole of the uterus or centralized uterus, then it is called sensor. So, lie is the condition here, this relation between fetus and long axis of the long of the centralized uterus or pattern. That is also so. So, lie is the relation between fetus with maternal. That is a longitudinal, the long axis of the fetus. So, lie is the relation between the fetus and centralized uterus. In cephalic presentation, that is a head, that is occupy the lower pole of this uterus. In case of breech presentation, the buttock is occupying the lower pole of the uterus. So it depends, incidents depend upon period of gestation. Since the earlier pregnancy, before 38 or 32 weeks, it is a high. In fact, it is more than 16 to 20, 30%, up to 25%. Also, the incidence is before 20 weeks or 32 weeks on this thing. But the incidence gradually requires when the progress that is a progress of pregnancy. When it is term after 37 weeks, it is almost 5%, and term 38 weeks around it reduced to 3%. So we'll come across around 3 to 5% at the time of delivery or the term delivery. But if it is a before term or pre-term, the incidence will be more or less. So this presentation, there may be depend upon this attitude of these babies. It could be the complete breeze, and incomplete breeze. complete breech where this all these parts of the interrelation of the fetal part of this, that is attitude, that is also complete breech. It is a normal, that is a flexion, universal flexion, that is incomplete breech where is the frank breech, knee presentation and foot link. So variety of breech will be complete or incomplete. Incomplete is again divided by the frank breech, knee presentation and foot link position. Let us come to complete breech. Complete breech. Let us come to complete breech. This is the attitude of the fetus. That attitude is the relation of fetal part with each other. The relation of the fetal part with each other. Here you can see the relation. That is all this universal flexion. It is in flex condition with the buttock. It is a hip joint is flex, knee joint is flex, all these things, shoulder is flex, elbow is flex. Within that flex, that attitude is that vertebra is also is flex. So head is flex also. So complete breech, when we call complete breech, where the fetus maintain the universal flexion attitude. That is so all the joints are in flex position. So it is the next section. Incomplete breech, we have three varieties, three parts. It is a brain breech. Brain breech, you can see that is a brain breech, that is both the thighs. So here you can see the hip is flexed, but knee joint it is extended. Extension of knee joint. It is a straight knee joint. That is extended. That is. Only flexion is and hip joint. Now, so this is a crank. This is crank bridge. All these three. And knee presentation. When we call knee presentation is when the hip is extended. Hip is extended. The thigh is extended. But leg is flexed at knee joint. That is knee presentation. And foot link. Mostly it is partial flexion or partial extension or partial extension. So in between the flexion and extension. So that is foot. You can put. Here it is foot is coming down. Partial flexion, all these things. Either one or both foot will be extended. So it is a partial flexion. That is its attitude is partial flexion. That's it. So in general, whatever breech we have complete breech, we have incomplete breech. In complete breech, it is universal flexion position. In incomplete breech, it is a frank breech where all the hip and knee are extended. Knee presentation, it is a hip is extended, but knee is flexed. And foot link, it is partial flexion. But clinical varieties, it is this. That one is the physical, that is the physical variety, that is the clinical variety is complicated and uncomplicated. So you can say complicated breech or uncomplicated breech. So if when there is no other associated complication apart from breech, so only breech is there, otherwise there is no other complication. So that is a antenatal complication. That is also uncomplicated. But when there is associated with prematurity, teen pregnancy, placenta previa, contracted pelvis, abnormal uterus, all these things, yes, subsected uterus, or this is arcuate uterus, then we'll say it is complicated breech. So, etiology of breech is in significant number of cases, cause is not clear. There is no method, but certainly there are some definite causes there. You can know this or blame are responsible for this breech patients. We know prematurity is most common. All these prematures, 20 to 30% patient will be having. If it is a less than 32 weeks or 30 weeks, we'll find almost that is 20% will be breech. Vector, that is so the breech also there is certain conditions, certain situation, you'll have breech presentation. Vectors, all this thing is twin pressure, multiple pregnancy because of two babies, parts is being all these things not adjusting to uterus also. So you will have abnormal presentation, oligohydramnios. When inside the uterus, normally baby keep on moving on this thing. So when liquor is decreased, there is no, baby is not able to move, particularly later half of the gestation when liquor is less, unable to move. So remain in a before position. If she was baby was in breech position before 30 weeks because of and later liquor is decreased, cannot revert back to cephalic position. Septate and bicutar, because of shape of uterus, it is designed like this. This cannot accommodate in longitudinal line. Sorry, that is the septate uterus. What that is septate or uterus? What is there? Some cleavage is there in middle. If it is the frontal septum, all this thing. So brains cannot occupy. In septate uterus also, one side it is bicuspid uterus or partial septum. One side there is a more space, other side there is a less. So baby is occupying in one side of the uterus. All this arcuate uterus like also because if it is an arcuate shape, it is also. And other thing is favorable adaptations. If it is a baby size, depending upon baby size or some pathological the baby, suppose hydrocephalus, the baby's head is bigger. So frontal, that is a frontus is a bigger than lower pole on this uterus. So head will occupy that. Placenta previa, there's a some person or space is occupied by placenta. So there is no sufficient place for occupying the breast. So breast will that the breast will above the placenta or sometimes it causes difficult in engagement also. Contracted pelvis, again there's a contracted pelvis because it cannot go inside the cell. So it will occupy above this. Cornofundal attachment. There's short cord also. If there is a movement of natural that version, cephalic version is not here. That is cornofundal attachment of lungs. Undue, that is again undue mobility of the fetus. Hydrominus, multipara with lax abdominal wall. There is easy reversion of this position can happen. Again, another that is anencephaly, all these things, all these things, they are temperatures. So etiology, all these things you'll see in oligohydramnios, bicuspid, sometimes the short cord hydrocephalus placenta previa because of this abnormal inside shape of the uterus that the body will occupy, that is in breech position. So how to diagnose breech presentation? So presentation, all this thing is because baby is going inside, outside you cannot see. Clinically, it can be diagnosis on palpation, all these things. So that is what is the frontal palpation. When you are palpating, when you have frontal palpation, you saw that the hard globular mass is there. Hard globular mass in frontal grid. Then you think maybe it could be the head of this baby. And it is, you can hold this like on this with the and you can hold the head and move it. That is palatable on this thing. So that is indicates is there. Then that is in case of punctuation. But in case of trains beat, it is may not be that is easily palatable. Though you can feel the head, but it is not easily moving. So irregular part of the side of the head because extended breeze again foot is extended. It should lie around the lateral side of the head, all this thing. So head is not palatable. Maintaining axon is there. That movement of the fetus will be restricted. So lateral grips, okay, definitely when you feel your lateral grip, you find some irregular part in one side and some smooth side, in one side, back of the side. It is not like this other that is cephalic presentation only. One side you have irregular limbs, other side it's big, smooth, relatively smooth limbs. And in irregular platters long because in this what happened that parts of this maybe is straightened. So you may not use multiple fetal part all this because all this food, all this thing, everything is at the head side. So lateral grip you may not able to, though you can feel some that but relatively less. Pelvic grip again this suggests breech presentation, complete breech what else? It is a broad thing will find soft, relatively soft, broad, irregular part will find all these things. And it is not adhesive because it is broad and wide, it is difficult to engage inside this. So sometimes you may be unengaged or floating bridge you can find all this thing. But in case of frank bridge, since it is a relatively smaller size, compact thing is there. Only buttock is there, that also head is extended. So there may be actually head breech will be head gases go inside the because it is conical shape, it go inside the easily can go inside this. If you find that is also, then you suspect that is a frank breech. Fetal health sound since the head is breech is not engaged, so relatively you will find it at the level of umbilical or maybe above this umbilical level, depending upon this left breech or sacroiliac or right sacroiliac, maybe left side or right side. And in practice, it is a relatively lower position because breech will go inside the pelvic bone, so you'll find the fetal head little lower level than that complete breech. During pregnancy, that is it. On PB, when you are doing pelvic examination, you'll feel soft, irregular, soft part there because buttock is there, the anus is there, sometimes it is. So all these genital organs, if it is a male fetus, you may be able to feel the testes or testicle cells also. So that is also that is there. And in case of frank beach, since it is very hard on this thing, engage inside, come down little down on this thing, sacrum may be felt. Sometimes it may be confused with fetal head because it is firm, hard is there. So sometimes you may confuse with fetal head. So that is also you can find all this thing. During labor, all these things, what will the qualification ischial tuberosity because it is come down. You can find the presenting part is that is trochanteric, all these things. So that is also that ischial tuberosity you may feel that it is soft foot, but sometimes foot may be felt all these things because universal flexion that is it. So you can feel the foot. And in case of frank beach, you may not able to feel any that is limbs, all these things. Only ischial tuberosity and sacrum is very hard to feel all this. So this is all this thing clinically diagnosis. Any doubt, anything during antenatal, though we don't have ultrasound during labor time, but ultrasound, we can confirm the diagnosis. Direct visual is in the head, what's the lower pole of the uterus, what on this. So you can just see the other thing. So that is such a lower pole of the uterus. Hello. And I am class in what? Yes. And then I am busy. I am in class. Just so confirm the clinical diagnosis. That is whatever you have diagnosis clinically, just you confirm it on the ultrasound. Congenital alarms, type of breach, that's also you can know whether it is a type of breach, it is as a complete breach, incomplete breach, all these things. So congenital anomalies, all these things, type of breach. So same time, you can also rule out congenital malformation if at all anything is there. Advantage of ultrasound is also you can measure the BPD, gestational weight, fetal weight, all these things. You can also see the placental causes of breach, placental localization, assess the lighter, that is, and attitude of the head, whether it is a legs breach or extended breach, all these things. So you can find all these things. So another advantage of also confirmation breach is even also the type of breach, it is complete or flex breach is there, that is any associated complicated factor, placental localization, assessment lighter, all these things you can make out very easy. So this is all this thing is there. So position all these things, because once bridge is there, you have to deliver the baby. You should know the position of the baby, position of the bridge. That is the position. So we have a four position when this position of the bridge is there. Position is this relation of this. Here presenting part is sacral anterior. Sacral anterior. That is it. So presenting part is sacral anterior. That is sorry. Uh, Presenting part is it is sacral. Denominator. Denominator is sacral. That is it. What is the position? Position is a relation of the denominator to the fixed body portion of the pelvis. Fixed body portion at the point of this room. So, this is the position is the relation of the presenting part also with the fixed bony pelvis also. So, as per this position, we have a four options: sacrum, left sacrum anterior, right sacrum anterior. Here you will see that is a left sacrum anterior, right sacrum anterior, left sacrum position of this thing. So left sacral anterior position 1, right sacrum at position 2, right sacrum posterior position 3, and left sacral anterior is, that is posterior is position 4. So we have a four steps relation of the denominator. So denominator, the relation of the denominator with fixed bony parts. So whether it is anterior or posterior. Because why you need to know all these things? Because the complication of the delivery depend upon the, that is the relation of this. Whether you can easily deliver baby, whether it is difficult delivery, you can predict the problem during delivery. So mechanism of labor, like all other that cephalic presentation mechanisms is like this. But difficulty is what is it? The difficulty is here is that is the breech has to delivery in three stages. In that cephalic position, once the head is delivered, almost rest of the baby will be delivered easy, except if sometimes shoulder dystocia, rest of it. But in case of breech delivery, this delivery will take place in three stages. First, delivery of the breech or buttock. Second was delivery of the shoulder and delivery of the aftercoming. So this is it. And it is first is easier, again it is more difficult. Third one is most difficult. So one has to be very experienced person to conduct this delivery. Otherwise, some complication will, you may have some reticence. So the mechanism of labor is very complicated, more complicated than cephalic with three stages. So delivery of breech on this thing is clear. So delivery is a breech on this thing. First, in first stage is delivery of the breech. That is the delivery of the buttock. So what happens is that the engagement occurs normally. So maybe that all these things, this the engagement diameter is right. trochanter. By trochanter, two metal bonds either side is there. By trochanter is there. That is in this. So engagement is by that. And one of the sacrum. We'll discuss left sacrum anterior. We'll discuss left sacrum anterior. One of these will just that the sacrum will occupy left. So sacrum is one position. We'll think of that sacrum is occupying a left anterior position. So what depends that is engagement of earth just that compact which also is there, that is most important. Similar to the flexion, that is universal flexion will be there in complete breach all these things. So it will come down, the descent will occur till that is like cephalic persons, what is the engagement, descent, flexion, internal rotation, lateral flexion, internal rotation, and external rotation and lateral flexion. Here also same thing. Imagine the sacrum anterior position. Here we'll see that is sacrum anterior position. That again there will be descent further till it touches the till it touches the pelvic floor muscle. Then internal occurs toward the that sacrum that is will come towards the one of the trochanter or buttock will come towards the in case of left sacrum anterior, that is all this thing. That sacrum that is buttock will come under the pubis, come towards the symphysis pubis, and there is so the moment it comes touches this area, there will be internal rotation. That is internal set till the anterior buttock touches the pelvic floor. That is also further descent. Internal rotation of the body, that again not exact. Like just cephalic version. It is on this thing, if it is vertical structure, it has to refer on this thing towards this impact. So buttock will, this anterior buttock will come behind this symphysis pubis. That is also. So till the anterior that the hinges behind the pubis, and same time that again that is delivery of anterior shoulder that followed by that lateral flexion will occur and delivery. This is delivery of the all these things. If any difficulty, little bit of this leak will be occurred. This is in case of that is buttock, delivery of buttock or delivery of breech. Again, when the breech is delivered, the buttock is delivered. Again, it has to deliver, the shoulder has to deliver. So how shoulder will deliver? Again, shoulder is in same direction as that is it's a breech also. Again, the same internal rotation will occur. That is here the engaging diameter is biacromial. Here it is a bitrochanter. Here it is this acromial. That is also the acromial process of the shoulder will come same direction as well. And it descent occur again gradually. This descent occur. Again, same internal rotation will occur. What will circle? That is also so that is also what is also that again this anterior shoulder will hinge behind the symphysis pubis and the posterior shoulder will deliver followed by anterior. Here anterior shoulder is delivering, posterior shoulder is delivering first followed by anterior. And restitution of the whatever is over rotated is revert back to the same position. So that is first stage is breech delivery, second stage is shoulder delivery. Again, most difficult thing is delivery of the aftercoming head. Delivery of the aftercoming head. What will happen here is again this that engagement again that is opposite direction. That is if sacrum anterior, then occiput will be that is occiput will be in opposite direction. That is also. So that is diameter. That is also. So this engaging diameter here is sub-occipital frontalis, sub-occipital in opposite oblique dimensions, and also sub-occipital. So again, descent will occur gradually till itself, yes, the flexor. So it is very important to keep the flexor intact. Otherwise, if it is extended, it will be difficult. So internal rotation of the occiput again along with one circle of this. Further descents in terms of changes under the symphysis pubis. This occiput is coming and the symphysis pubis. Then head is borne by first thing is chin will come, the mouth, nose, forehead, and buttocks. Then occiput. That's why this has to be rotated. So baby has to be lifted above all these things so that chin, mouth, nose, forehead, all will come gradually. So this is also. So you'll see this is this mechanism of left occiput, left sacral anterior. Here all this thing internal rotation occurs. Once it touches pelvic, the internal rotation occurs. This anterior buttock will come behind this symphysis pubis. Here it is coming this side. Again, that is also here it is anterior shoulder is delivered. Again, coming this thing. So this is all this thing. Again, that is gradually, that is again, baby will come down and down here, all this thing. First thing on this is the shoulder will hinges behind the symphysis pubis, then posterior shoulder will be delivered. After coming here, occiput will occupy again the posterior symphysis pubis, all this thing. Here, flexion has to be maintained, all these things. So, suprapubic pressure is there, so the flexion is there, engaging diameter will be reducing all these things. Gradually, chin deliver. One that is occiput is here, then chin deliver, mouth deliver, nose deliver, then brow deliver, then buttocks deliver. So like this, the mechanism of this is delivery. So prognosis, all these things depend upon this period of gestation, depend upon the associated complications, all these things. Complicated, that's what I'm talking complicated is. So this is all this thing is. So maternal because of increased operative delivery, sometimes you read that is associated has to be here. Sometimes you have to abdominal incision over the cervix, all these things. Injury to the SHH because manipulation will be so not only maternal morbidity, that's morbidity maternal will be increased. So perinatal modality is not is a higher than the normal cephalic position. So perinatal death will occur 3 to 5 more percent. So fetal mortality least in breast delivery because it is easy to deliver maximum in foot-link presentation because foot that is pot prolapse, foot engagement, trapping of this head, partial dilatation of the cervix, all these things. So everything depends upon skill of the search. Facilities above, neonatal facilities, anesthesia facilities, all these things. Because most of it is vaginal delivery of the breast is difficult than the cephalic delivery. So nowadays, that's why maximum people obstetrician favor cesarean section, elective cesarean section in this thing. So friend, another thing that is it. Now everybody prefer to do elective cesarean because it is not a problem free, it is without not without complication. Some complication will be there in this delivery when everything is normal. Fetal danger again because of prematurity intrapartum fetal death is also reported injury to the brain because most of the time if it is a foot-lick presentation after coming breeze will be there that is also and particularly immature baby there is in case it is also intracranial hemorrhage. So intracranial fracture of the skull, fracture of the shoulder, fracture of the clavicle, injury to the scrotum, injury to the vulva, all these things will be there. And it is a time consuming because it has to take 3 stages, breast, shoulder, and after coming. Then definitely absent the time will be consuming. So birth injury, hematoma, stenomastoid thigh, or the fracture of femur, humerus, clavicle, all these things can possibly happen. And in case of the test, if it is a 7th, 8th nerve is involved, that's up Even cerebral palsy is very common because intracranial hemorrhage. Cerebral palsy is due to intracranial hemorrhage that is caused. So this is a long-term complication in this thing. So to prevent all this complication, I think is even is normal pregnancy without but complication or uncomplicated breech also, that mortality, maternal morbidity and fetal mortality is very high. So that's why I told you now very often as obstetricians choose to do elective cesarean section instead of going the vaginal breast delivery. So for that, even if you are doing, but sometimes there may not be OT facility, the patient may lie with come in last stage, all these things. So we have to deliver breast delivery. So every obstetrician learn the technique of breast delivery, should be expertise in conducting breast delivery. So that is the skill of obstetrician person. When you are dealing with breast, you should be remember all these things. It is not easy delivery. Some problem may come, so we need to go for the cesarean sections at the time of breast delivery. So anesthesia should be there. So OT facilities should be there. That is it. So most often you get that asphyxious baby, in particularly preterm baby. So neonatologist should be there. Not only neonatologist should, that is infrastructure for neonatal medicine. Infrastructure for neonatal physicians. So management, how to management. So early diagnosis, you have diagnosis also before delivery. Patient is under antenatal care. You know this freeze, breach, all these things. There is no chance of spontaneous abortions, all these things. Then you can say, if it is there is no spontaneous, you can plan according to medicine. So basic ideas that you can do the external cephalic version. That's external version is correction of the position. That's converting the breech position to cephalic position is sometimes converting the transverse position to cephalic position is called cephalic external cephalic. It can be thrown down from outside per abdominal. We need not monitor internally, that is also. So breech pregnancies, you know all these things up to 30, there is a higher percentage, all these things is common. And if by the time of 36 weeks, it may corrected. But what is not corrected after 36 weeks, we should be worried for this patient. So external cephalic version can be done at around 36 weeks or after 36 weeks before understanding. It can be done just before delivery also. That is it. It's very before delivery also. So we can do successful version 60 to 70%, but there is a chance of reversion. Revert back to the breach is also a possible thing. It is. But here that is cephalic pulse is bringing it down here to the lower pulse. So it is timing of external cephalic version is timing of cephalic version is around 36 weeks. After 36 weeks, if you do early before that, again the revert back of the reversion is also is there. So it is the ideal 36 inch with the size of the baby is sufficient, breaker is also adequate, all these things. So before that you have to get breech delivery, where you will do. If baby size is very big or very small, it should not be done cephalic version because they are danger of fetus ulcers. If liquor is less, it should not attempt for this. If there is a cesarean, previous cesarean section should not be done. If there is a contracted pelvis, it should not be this. So before that, you should fulfill certain criteria. That is, so incidence of this item is decrease incidence of this value. So idea of external support goes convert into the thing. Don't go for breech delivery, better go for cephalic delivery or what is it. So in hepatic break, it is head is concerned. So we try to decrease the cesarean section. That is it. So complete this. The successful thing is there, that is if it is a complete freeze, non-encased freeze, sacro-anterior position, better freeze. These are the better cells, adequate liquor, non-obese patient. And failure sometimes, okay, if it is extended freeze, it not possible to rotate this thing. Short cord, again there is a danger. Uterine malformation, again it is a scanty liquor, a big baby, mechanical obesity mechanical obesity or the deficiency. So how we will do all these things separate person? That is also again before doing example, you have to explain what is the consent is also required. Take consent of this. You have to judge what is the use of external supervision, what is the merits and demerits, what is the advantage, what is the disadvantage, what is the complication. You have to explain the patient. One criteria is there, you have to see the fetal headers and you have to confirm liquor is adequate, there is no anomalies, there no anomalies, uterine or fetal anomalies. Then once it is rule out everything, you go for the patient is keeping looking after emptying our pages, head may be little bit very slightly rise high or facial plexus, all these things, it is there. Then again what we will do little bit disinfect the baby. If its breech has come down to the pelvis, disinfect the breeches. One hand put in the syphilic position, that is one hand put in the fundal position where head is situated, other right hand, and if you are left right-handed person, and it is sacro anterior, left sacro anterior, then you put your right hand like that Pauling clip, all these things, put your left hand over and again compact the breast, compact the face and so that maintain the flexor attitude of this one. And gradually, before that, maybe some prepare to do some tocolytic, all these things is there, that is relaxation, so we can easily do things. Then one is a concept, then again that's just a take this. Gradually, head is moved, all these things head is moved towards the opposite direction and breast is moved away from the pelvis, all this. Sound natural exercise. So gradually, when the relaxation is there, if it is contracted, you are not doing this shortness. So here what we are doing is one breath is left, right side is contracted left side. And pushing, pushing this breath toward away from the pelvis, all this thing, gradually all this thing. After each event, what the movement, the fetal heart should be. If any liberation of fetal heart, it has to be stopped. So this is all this thing. Once it reaches in transverse position, again that hand has to be exchanged because you cannot cross hand like and do this manipulation. So it is there that it is one head, keep one head here, again put other head here. Don't remove both hands simultaneously. Just let us put one head, remove this hand, again this is it. So this is again this foot. I'm showing it here. It is again this is there. So once you put on this thing, again it is this. So again, you try to push the head downward on this thing. So again, this is now your head is changed. This head has come this side, other head is this side. So this is your change. You are not crossing your hand, but you are not crossing your hand. So this is delivered. This is encephalitis and contractitis. And NST should be. You should monitor the fetal heart, all these things for 10 minutes. And we should see that is if there any other bleeding is there because abruptio. There may be occur of the port entanglement, abruptio may be there, may be rupture of the membrane. Possible thing can occur, all these things can occur. So you have to observe at least for 30 minutes, everything is okay. In case of RS negative, you can give anti-D all these things. So danger of backside, call this thing when you're doing all this manipulation, you may have this premature set of labor fear of placenta or the bleeding, all these things. So cord entanglement inside all these things. Not fetal metabolism, amniotic fluid imbalance. So this can happen all these things. So it's of this process, during this process, each movement, after each movement, you have to monitor fetal contraindication again, anti-catamenitis placenta absorption. Fetal causes hyperflexion, hyperextension of the head, large fetus for the patient. It is very small IUD baby. We are not doing all this manipulation. Multiple pregnancy, you are never doing any birth all these things. Only after delivery of the first delivery, you can do. So, rupture membrane can occur, congenital malformation, there may be problem, they are not contracted well with, they are not try to do all these things. Previous cesareans, I already told these are the all these things. Isoimmunized baby depression also. And bed of static history. Remember bed of static. Never go for straightforward, go for cesarean delivery. Indication of cesarean section, that is. Indication of your if there is baby is very high, use your 3 term baby, any degree of fetal contraction, hyper extended in this thing. We have to go for the cesarean section. We are not going to do any exertion, port collapse, descent of the thing. So this is all this thing. So vaginal delivery, all these things when you are different. So vaginal delivery is not we allow her spontaneous delivery. Here no manipulation is required. Assistant based delivery. That is very rare, only 10%. Assistant, majority of the case we are doing is assistant based delivery. It's whenever necessary, we intervene. Otherwise, no need to. Total breech extraction. Here, that is big extraction. All this breech will be extracted. So, normal vaginal breech delivery is either spontaneous breech delivery, assisted breech delivery, or total breech extraction. Management of starts and race, all this thing is there. That is also all this thing. Fetal heart will be made of like all other cephalic versions of the fully extended breech fear of port collapse. All this thing has to be. Because if we put link progress, anytime the membrane is ruptured, we have to do it. Incidence of this foot link, the port collapse is very high in foot link presentation. So you have to be very careful during first stage all these things. Management in seconds and depend upon all these things is level of assistance required all these things. Or the base delivery of because a tertiary center where the facilities for anesthesia, OT, neonatologist, and this that is a neonatal unit should be there. That is also recognized. So resuscitation unit should be there. That is the place where we can conduct deliveries. As I told you, it is spontaneous speech delivery, not quicker because you are not doing anything. Sometimes assistant, majority of cases, assistant speech delivery are conducting assistant. Breech extraction, where the delivery is not necessary that you have to extract the lead. Like this patient is coming in second delivery, cord follow-up, extend the leg. Mostly patient is coming in second stage and not able to deliver. Assisted this delivery, that is a planned delivery. We have to plan all these things. So anesthesis, artificially cesarean section, contact cesarean section, etc. So this is all this thing we have to do with assistant. So assistants are giving this to majority, particularly smaller that is smaller the baby, bigger the when you are giving all these things, all this thing episode is given in normal cephalic presentation, climbing of the here it is climbing of the periphery. It is all this thing. You remember climbing of the periphery. That is all. So assist this delivery when you are just interfere only when it is necessary. Otherwise, little interference is required on this thing whenever it is necessary. Other it is necessary. So it is a spontaneous delivery, but whenever necessary, will intervene on this thing. With it is uterine control, this investments not involved. Takes and food may report in present are releasing it. Suppose breeze is coming, but of all these things. Food is there that gradually just food, the food is release the food. This is all this when there is a movement that is. And when this baby breeze is delivered, that what is it? Just cover with the baby with warm towel, all these things. So, only we have to see where anything danger is suffering, any complication is. If part is side of this, you keep it in between thigh and the lips of this. Covering the body with towel, all these things. That is what this body baby steady, but not traction is there. First thing is don't pull from below, on this rather push from this abdominal side. So don't pull, only pushing from outside. That is inside. To try to mention the flexion situation. So this is all this thing is there. So that is it. Baby is delivered over the baby, then it is treated. This head has to be turned on the anterior side of this abdomen of this thing. So let us say arm is being flexed at the elbow, hooking the shoulder delivery. Gentle hooking. Posterior arm is brought at the anterior, flexed with it. Then that is yes. If not flexed, it is there is delay lopsided management. So in complicated this, a nochial displacement of this is normal. All this thing is if it is a complicated thing, then what will be that is a difficulties extended. And just in this case, here it is delivered extended arm is there. It is able. In this case, what will be said? Sometimes anteriorly limb head is anterior, sometimes is process. How will know if winging of this scapula is there, we will know all this. So there are three management. One is classical management, intrauterine management, and general other is lopsided management. From outside, don't put your head inside onto the outside. So that is lopsided. So the classical management also we put because inside head, inside all these things. Head has to be sweep, rub the anterior side and bring anterior side. Again, that is posterior head is put inside, again bring this and out this. But if it is nuchal displacement, you have to rotate this lopsided maneuver. All these things here. So lopsided maneuver is hold the baby outside all these things, rotate this baby once. So limb will come to anterior side. Then you just look out in this like this. Again, opposite direction. Both the arm is extended opposite direction. Again, rotate all this. So the head will come in anterior side. Then you put out the distance. So after delivery, both arms, the child hang down from the vulva outlet. This is basic. That burn muscle technique. Once the patient is always thing, let it hang on it. So the flexion attitude will be maintained. So flexion attitude will be maintained all these things. Again, that's just a head is delivered as I saw all these things fast. And put your head, keep your hand baby all these things. And once you hold all these things, that occiput is delivered, that is some this is vision, then you can hold the baby all these things and move around like what will be burn muscle to this all these things. Then chin will deliver, face will deliver, nose will deliver all these things. Delivery of upper tongue, that is all this burn muscle method versus delivery or body this. So burn muscle method is put this baby on the mark on this thing. Then once this baby is let it hang on its own subflexion. One occiput is there, then hold the baby and move forward. That is it. Forceps delivery, then we are using if it is a difficult and it is ideal because it's a gradual release of the pressure, all these things is there. So ideal forceps is this is Piper's forceps where there is no pelvic cord on this thing. So we put Piper's and deliver. Modify smelly bed technique. In this case, what is this? That's part of the head. Left hand is put, two finger index and ring finger is put with the prominence of this baby. Other hand is put on this thing is that's occiput presence. And that index little finger and that is thumb is put in shoulder and try to mention all these things flexion. In this case, we take out baby. That is here. That is also bar martial technique is there. That is also bar martial. Let it take some flexion is mentioned. Once it is there, hold this baby and pull. This is bar martial. This is hyperplasia, all these things. That is all this baby. So gradual delivery of this baby. So this is all this. That is the Mauritius medicated. Modified is what earlier days we put this middle finger inside the mouth, all this thing, but now it is avoided. Only this ring finger and index finger is put in the male combination, and your other head that is also up and all this put in other that is just to keep the baby flexion attitude, and it is just delivered. So it's this bridge delivery is complicated delivery. Before doing all these things, you have to assess this pelvic, everything is there, to contact the higher center on this thing. That is so that is and so it is what it is there. Again, you have to insert the cervix or this perineal area, vulva, all these things, injury to all these things, tear of cervix, all these things. Complication, there may be complication, very common, it is occurred with there is a fully extended space complications after have stuck after coming head on this. So it is not attempted to make extra space where there is cervix is not fully dilated. So that is after treatment of or trapping of the after coming or the partial damage. So in this case, you can give a duration incision. That is a 2 o'clock position and 10 of it. And baby is delivered. Duration incision. Sometimes you come across with collapse of cord. If the cord collapses there is no option. Push this baby head up, and without removing your internal finger, you have to do cesarean section. It is extended arm. I told all these things, left side maneuver, and that is classical maneuver. Difficulty in after coming here to solve this thing, we can focus on the dilated cervix. Either you can use Murmu technique or forceps delivery, or if it is partial dilated, DSM incision. Extended reason. In this case, is extended this opposite of the it's based on this thing. In this peanut butter, that is extended arm. Here, what you are getting, it is a frank brace. Most probably you do it with frank brace. All this is your this head into the vagina. Finger is guided or possible and try to do it with. Once you reach completely the poke here, that was again you once you click this, first put pressure on this completely of pressure, and you'll see that there's a little then move down this keep put down your foot and just deliver on this thing. Occiput posterior again, that is on this thing is it is same as on this thing. Only internal rotation to the opposite direction of this thing. Here instead of that is that you have to maintain the flexion of this one. Here it normal wrist deliver occiput posterior what we are doing that is such a maneuver technique. Here it is the just opposite, that is front maneuver. Head is delivered first to this reverse direction. That is it. So your head is delivered first to this by reverse color flexion also. So you have to put on this other side. That is it. Methods of delivery. Impacted breech, disproportionate size, all these things. If it is impacted, there is no point. If it is the cesarean section, this baby is alive, cesarean section, but rarely you will find impacted ribs, baby is alive. Even if it is impacted, shoulder is impacted, all these things, you have to go for cesarean section. Only so prognosis is 2 to 3 times more than the occurs with this fetal mortality is higher than the normal vaginal delivery. Trial can be met if everything is fulfilling all these things, trial of labor could be given. But if it is more than 3.5 cases, we go for the cesarean. If it is less than 1.5, we go for the cesarean. Only average size adequate pelvis, breech delivery is allowed. For the disc delivery, there is a score is there, that is the underscore, this scoring is there. You have to do scoring system for all these things. So once you see that this scoring is fulfilling your character, then you have to do. Otherwise, go for cesarean. This is all about breech delivery. So you're completing breech delivery, go through your book on this thing unless you practice with your that is pelvic body pelvis is difficult to remember. So go through the book today itself and read it. Okay, thank you. Let us stay home, stay safe.